Hi, everyone. Welcome to our June session for the Neonatal Hemodynamics Research Center and PanAmerican Hemodynamics webinars. I am very excited to invite everyone here today to listen to an exciting talk by Dr. Poorva Deshpande. Before we start with this session, just a couple of housekeeping items. I want to remind everybody that this session is recorded and will be available on the Neonatal Hemodynamics Research Center YouTube page. I will put a link in the chat box so that you all can see it. We will also be answering things live on Twitter. If you would like to hashtag us or post things on Twitter as we go through the talk, I will also put a hashtag and the Twitter form there. As always, you are invited to join us on the Hemodynamics Research Center YouTube page. You can like and follow us, and if interested, can reach out to hear more about the American Society of Echo and Neonatal Hemodynamics, Targeted Neonatal Echo Special Interest Group, and how you all around the world can be more involved. So without further ado, I would like to invite Dr. Poorva Deshpande, who is a staff neonatologist at Mount Sinai Hospital, Toronto, and an assistant professor in pediatrics at the University of Toronto. She has completed her neonatal perinatal fellowship training at the University of Toronto and also completed her targeted neonatal echocardiography and neonatal hemodynamics training at the Hospital for Sick Children. Her research interests are quite vast, as she has done an amazing job looking at cerebral monitoring, cerebral hemodynamics in the preterm infant, and trying to use some of these non-invasive tools, including amplitude integrated EEG and targeted neonatal echocardiography, to better guide precision medicine in this high-risk population. Without further ado, I would like to invite Dr. Poorva Deshpande for her talk on precision in the transitional period for extremely low birth weight infants. Thank you.
Thank you, Lauren, for this very generous introduction. I hope everyone can hear me and see my screen. So I have just slightly tweaked the title of my talk from precision in transition in extremely low gestational age infants to transitional hemodynamics in extremely low gestational age infants, from physiology to precision. Just to reflect the journey that I hope to be taking you through in the next 30 minutes or so. I have no disclosures. So I'm going to start with addressing some basic physiological aspects of transition. So birth is a unique physiological event that brings about sudden and complex changes that involve multiple organ systems. So we know that during fetal life, the lungs are fluid-filled and gas exchange primarily occurs at the placental level. At birth, the major event that triggers a series of dramatic changes is the onset of breathing. So when the baby starts breathing, inflation of the lungs moves the fluid out from the alveoli into the interstitial space, which leads to a significant decrease in the PVR, or the pulmonary vascular resistance. Simultaneously, the removal of the placenta from the placental circulation, from the systemic circulation, also causes a sudden increase in the SVR, or the systemic vascular resistance. And this rapid shift in the PVR-SVR ratio alters the directionality of the PDA shunt from right to left to a bidirectional or possibly an exclusively left to right shunt. And the increase in the pulmonary blood flow that elevates the left heart preload and raises the left atrial pressure, which then leads to the closure of the foramen ovale. So during transition from intrauterine to extrauterine life, there are notable differences between the term and the preterm population. So in term infants, the left heart preload is determined by lung aeration. So when the lungs expand and become oxygenated, the left ventricular preload increases. Because in preterm infants, the presence of lung disease can lead to high PVR and subsequently reduced preload. When it comes to the myocardial adaptation, term infants experience a rapid increase in the LV stroke volume within minutes after birth. Whereas in contrast, in preterm infants, who have an immature myocardial contractility because of multiple reasons. They have just fewer myofibrils. They may have a simplified internal organization within the myocardium, an immature sarcoplasmic reticulum. And these factors contribute to less force generated during contraction. Additionally, preterm infants also have a decreased number of beta-adrenergic receptors and less sympathetic innervation, which further impair their contractility. In term infants, the closure of the foramen ovale and the ductus arteriosus is a normal physiological process that in majority occur by day 2 for the PDA, and the foramen ovale can functionally close up to hours from birth. However, in preterm infants, the closure of the ductus takes much longer. In fact, we know from the data from non-intervention studies that the ductus can remain open beyond the first week of life in up to 90% of infants who are born under the 25 weeks gestation age. In addition, the functional closure of the foramen ovale can also be delayed in many premature infants. Additionally, preterm infants also have end organ immaturity due to the anatomical structures being less developed compared to term infants. So because of these factors, preterm infants are particularly vulnerable to various disorders during this critical period of transition, which can significantly impact not just the cardiovascular system, but many other organ systems and the overall well-being of the infant. First is pulmonary hypertension, but because this is such a specified topic that has been covered by other experts, I'm going to opt not to cover it during my talk today. So other than pulmonary hypertension, the other commonest complications in this period are hypotension, pulmonary hemorrhage, and the one that has probably the most long-term, long-lasting impact, which is intraventricular hemorrhage or IVH. PDA almost overlaps with all of these and obviously has an impact on its own on many other organ systems. So the most widely accepted theory for IVH is hypoxia followed by reperfusion. So preterm birth is often associated with infection, inflammation, or placental insufficiency that may lead to hypoxia in the fetus as well as the newborn. This may be further confounded by respiratory insufficiency, which ultimately leads to cerebral hypoxia. Now, the preterm myocardium, as I've just said, has poor capacity to increase contractility immediately in response to the high afterload after the clamping of the umbilical cord, which leads to decreased cardiac output, which further contributes to cerebral hypoxia. Now, after resuscitation, there is restoration of oxygenation and tissue perfusion. And also as the myocardium adapts to the loading conditions and the PDA shunt becomes more left to right, cardiac output then increases, leading to reperfusion of the brain, which ultimately leads to IVH. Now, considering the timing of events, it is interesting to note that the peak incidence of hypotension is on day 1, that of pulmonary hemorrhage is on day 2, and that of IVH is on day 2 to 3. Now, during this time, the other thing that is also happening is that the PDA shunt is increasingly becoming left to right. And this is further supported by studies that show an association of grade 3 and 4 IVH in infants who had pulmonary hemorrhage. So this temporal association of PDA, pulmonary hemorrhage, and IVH definitely leads to the next question, which is this just an association or is there a causal link? And a mechanism that we postulated may provide some biological possibility on the role of PDA in this hypoxia reperfusion event. Immediately following birth, the left ventricular output is relatively low as the developmentally non-compliant preterm left ventricle takes longer to adapt to the sudden increase in the loading conditions. Now, as the pulmonary vascular resistance drops, the ductal flow becomes exclusively left to right, which lowers the SVR. In the absence of cerebral autoregulation, much of the LVO is preferentially sucked downstream towards the path of the least resistance, towards the lower body, which may result in relative cerebral hypoperfusion. Now, between day 1 and 4, as the LV recovers, the LV output initially normalizes and later increases in response to the increase in the left heart preload because of the ductal shunt. And now, because the brain is a preductal organ, this increased LVO can directly increase the cerebral blood flow, especially in the absence of cerebral autoregulation, which then subsequently may lead to IVH. Again, this is just a postulation because we don't really know the exact cause of why PDA and IVH are linked. The other important pathology is pulmonary hemorrhage, and the interesting timing of pulmonary hemorrhage, which is typically day 2, also coincides with the other pathologies. So is pulmonary hemorrhage solely a problem of increased pulmonary blood flow, or is there something else going on? So there seems to be a combination of factors here. There definitely, as the duct starts shunting left to right, there is increased pulmonary blood flow and increased pulmonary venous return. However, this also occurs at a time when the LV is in a state of relative dysfunction, which results in left atrial hypertension, increased capillary pressure, which then further results in pulmonary hemorrhage. So since the pathologies overlap, does the treatment for one offer any benefit over any other pathology? And the TIP trial is an excellent example of this. So the TIP trial showed that indomethacin prophylaxis leads to decreased incidence of severe IVH, less PDA, and less surgical treatment of the PDA. But it failed to show translation into improved long-term neurodevelopmental outcomes. And so the authors did not recommend routine use of prophylactic indomethacin. In fact, what they have said in their discussion section is that we must look elsewhere in our quest to reduce high rates of adverse outcome in extremely low birth weight infants. So with this example, I want to highlight the need for precision medicine in neonatology. So like many other therapies in neonatology, prophylactic indomethacin, which was an IVH-specific preventative strategy, was also tested at the entire population level. And this kind of one-size-fits-all approach has its own challenges. So firstly, it needs a large sample size, which may result in undesirable exposure to the lower risk patients. And it also may limit its clinical benefit. And that's why identifying the highest risk patients for targeted interventions may allow to see a maximal clinical impact. And one such attempt was the DETECT trial, where the high-risk population was clearly defined. So only infants with a PDA more than 1.7 millimeters on a screening echo at 6 hours were included in this trial, and they were randomized to receive either indomethacin or placebo. Unfortunately, this trial had to be stopped early because of non-availability of indomethacin. Nonetheless, they did show a decrease in pulmonary hemorrhage from 9% in the treatment group and 23% in the placebo group, and a decreased need for late PDA treatment, which was 20% in the treatment group and 40% in the placebo group. Unfortunately, they could not complete this trial, and there was no difference in IVH that was noted in the results. An excellent real-world data example of the use of targeting the highest risk population and the use of precision medicine is the recent data from Iowa. So Reagan here showed how, compared to a historical cohort, the use of an early hemodynamic screening and targeted treatment of PDA with acetaminophen showed reduction in both death and severe BPD at 36 weeks, as well as that of severe IVH. And after adjusting for confounders, the hemodynamic screening was found to be the independent factor associated with improved outcome in this cohort. So let us talk about precision medicine, and I'm just going to read out the definition here. So precision medicine can be defined as a structured approach to treat or prevent specific diseases based on inter-individual variability in genes, diseases, or lifestyle. This concept holds promise to improve management, prevention or treatment, and subsequent outcome in critically ill newborns. So obviously precision medicine is only in its infancy in neonatology. When I searched precision medicine and neonatology in PubMed, it yielded only 311 results. And so conceptually, here is a description where in empirical neonatology, all preterms receive the same treatment. In precision neonatology, the treatment is stratified to a specific group of babies. And in individualized neonatology, the treatment is tailored for each individual infant. So the transitional period is actually ideally suited for precision medicine and individualized medicine for a variety of reasons. Firstly, it provides a finite window for neuroprotective strategies. Secondly, infants exhibit varying phenotypes during this period, with not all infants having a complicated course and different infants showing different types of complications. And thirdly, the complications in this period represent a huge burden in the extreme preterm population. This graph here shows the trend of grade 3 and 4 IVH in Canada that has not changed in the last 10 years. And one of the reasons it is important to tease out this granular details is because intraventricular hemorrhage involves complex physiological interactions of the host with various factors, such as low flow states, PDA, hypotension, infection, CO2 changes. And teasing out all these specific factors is a challenge. And so identifying the at-risk population is also a challenge. And so what are the different biomarkers that we can use to identify this high-risk population? So first is clinical or demographic data, which is the use of antenatal steroids, the gestational age, sex, inborn versus outborn. There could be physiological data, such as blood pressure, heart rate, systemic hemodynamic variables obtained from echocardiography, and brain health markers from cerebral oxygenation and AEEG. Scoring systems for prediction of IVH using demographic factors have been described. And although they do help us in prior identification of at-risk infants, the risk factors such as lower gestational age, birth weight, race, or SNAPI scores, they're largely non-modifiable factors. Now, studies on hypotension in transition and its long-term risk have shown conflicting and confusing findings, where one study, the top study here by Batten, shows that treatment of hypotension carries a high risk of IVH, while data from the EpiPage cohort here at the bottom shows that non-intervention is associated with worse outcomes. And again, the need for a more refined approach in understanding the pathophysiology of hypotension is important before treatment. And Jose Aldana Aguirre has nicely shown this in this study. So Jose looked at babies with transitional hypotension who had an echo, and he did a matched case control study. So he matched babies who had echo, but who did not have hypotension. And what he found was that babies with hypotension had a higher frequency of PDA and a larger PDA diameter. The markers of LV function were same in both babies, both groups, except for increased fractional shortening in the PDA group, which was likely related to a low afterload, which was because of the PDA shunt. Now, individual studies that employed sequential echocardiography during transition have shown that infants who later develop IVH have low SVC flow as well as low LVO, which imply an early low flow state. And in contrast, our own pilot data showed that infants who developed severe IVH had a later rise in LVO. So they had a higher LVO than the third quartile of the infants with no IVH. In the same cohort, the 4 infants with severe IVH also had lower than the first quartile for cerebral oxygenation. So that's the shown in the red circle. And this was seen early before 18 hours, whereas IVH on serial ultrasound was only detected later after the 72-hour mark. Although this was a small sample with a small number of infants who had severe IVH, so not major conclusions be taken from this data, but a large number of studies over the last decade have consistently shown the same finding, that infants with IVH have a comparatively lower mean cerebral oxygenation during transition. Now, because in practice, not all centers have the access to cerebral oximetry, we attempted to study the correlation between cerebral oxygenation and markers of systemic blood flow, such as LVO, RVO, SVC flow, as well as blood pressure and its components, so systolic, diastolic, and mean blood pressure. And we found that there was consistently a poor correlation of cerebral oxygenation with all these markers of systemic flow across different 4 time points during transitional period. So at 4 different time points in the first 72 hours. So the likely underlying reason is most of the infants in our cohort were clinically stable and likely to have had an intact cerebral autoregulation. Now, majority of the audience are probably familiar with this autoregulatory curve. And so autoregulation is essentially the capacity of the brain microvasculature to adjust the cerebral blood flow over a wide range of blood pressure. And technology has allowed us to study autoregulation as a biomarker that can be measured at the bedside. And so the concomitant measurement of cerebral oxygenation using NIRS, as well as continuous arterial blood pressure, enables the evaluation of dynamic autoregulation. So in this example, in the highlighted part in the graph at the bottom, cerebral oxygenation changes with the mean arterial blood pressure, which implies a positive correlation, which is seen here at the top. And therefore, it implies a poor autoregulation. So this particular concept is called cerebral oxygenation index, which is only one of the methods to study autoregulation. And a cutoff of 0.5 is thought to indicate altered cerebral autoregulation. So indeed, babies with severe IVH spend more time with cerebral autoregulation and cerebral oxygenation and mean blood pressure correlation above 0.5, which is the horizontal line, as compared to those who did not have severe IVH. Now, with the increasing enthusiasm in cerebral NIRS, it is important to establish its utility in improving outcomes. That has obviously prompted researchers to conduct clinical trials. And the SAVE-POOS-3 trial, which was one of the only 2 RCTs on cerebral NIRS, was recently published. And in this trial, about 1,600 babies were randomized to receive either standard care during transition or management based on their cerebral oxygenation. So they used this comprehensive treatment guideline, which provided guidance on the steps to be taken if cerebral oxygenation levels dropped below 55%, or to the corresponding values using different oximeters. They did use a tailored kind of physiological approach, which allowed them to target various aspects of management, including ventilatory management, blood pressure management, PDA treatment, blood transfusion, etc. And they showed no improvement in their primary outcome, which was death or severe brain injury at 36 weeks corrected, or in any of their secondary outcomes. So of note, a change in management was done in only 29% of patients in the NEARS group. So where do we go from here? Do we discard NEARS as just a fancy tool, but a useless tool, or are there more questions to be answered before we embark on further clinical trials? So firstly, in the studies on cerebral oxygenation values, although the babies with IVH did have lower average values compared to those who did not, their values still fell within the described normal ranges. And so targeting values alone may not be sufficient. The discriminatory thresholds for cerebral saturation to predict IVH, as well as the exact time during transition where they have the best discriminatory value, is unknown. Secondly, is a lower cerebral oxygenation value merely a sign of an underlying pathology? We definitely need more mechanistic insight into what really drives the low cerebral oxygenation. Is it altered autoregulation, or is it other hemodynamic components such as cardiac output function, the role of the shunt, the role of the ductal shunt? And finally, it's targeting one component alone sufficient to expect change in outcomes. And perhaps the use of an integrated multimodal approach using a combination of biomarkers may help us not only to understand how to identify the highest risk population, but also to understand the mechanisms of disease processes. So we demonstrated in a cohort of 50 extreme preterm neonates that it is feasible to apply such a multimodal approach during the transitional period, using sequential echocardiography, brain imaging, as well as continuous NEARS, as well as EEG monitoring. And we are hoping to answer some of these questions in our upcoming Pioneer study, where we aim to examine the discriminating characteristics as well as the time during transition, where cerebral oxygenation, as well as autoregulation measures, measured at every 6 hourly intervals during the first 48 hours, has the best discriminatory value for predicting IVH grade 2 and above. We will also study if echocardiographic markers such as LVO, SVC flow, PDA diameter, individually or in combination with cerebral oxygenation, improve the predictive value of IVH. And by using a combination of markers, we also hope to gain some mechanistic insight into the cause or the drivers of low cerebral oxygenation. The study is soon going to be launched at 4 Canadian sites, where we'll be using continuous NEARS monitoring for the first 48 hours. We'll also be using 2 echoes and 2 head ultrasound, one within the first 24 hours and one between 48 and 60 hours. And finally, we are entering into a whole new era of artificial intelligence and machine learning algorithms. And some fascinating preliminary data is just coming up. In a recent secondary analysis from the HIP trial, Jean Dempsey's group looked at the prediction of grade 2 to 4 IVH using an algorithm that used prolonged cerebral desaturations and SpO2 data. And they showed that the model using prolonged desaturation has the best discriminatory potential with an AUC of 0.85. So that is likely where the future of precision medicine in neonatology lies. With this, I am going to stop and thank you for listening, and I'm open to take any questions.
Thank you, Poorva, for that excellent talk. I would like to invite our panelists and my co-moderator to join us. Our panelists are Dr. Khorshid Mohammad. He's a staff neonatologist at Alberta Health Services in Calgary and a clinical professor of pediatrics at Cummings School of Medicine and University of Calgary. He's established the Neonatal Neurocritical Care Program in Calgary in collaboration with pediatric neurology. In addition, his quality improvement work has led to significant reduction in mortality and brain injury in extreme preterm infants and term infants. I'd also like to invite Dr. Souvik Mitra. He is a neonatologist and associate professor of pediatrics appointed with the Department of Community Health and Epidemiology, which he has his PhD in Halifax, Nova Scotia. His research projects currently include a pan-Canadian project on the comparative effectiveness of non-steroidal anti-inflammatory agents for the treatment of the PDA in preterms, and a CIHR-funded multi-centered RCT on selective early treatment of the PDA in extremely low gestational infants. And lastly, I would like to invite Dr. Brady Thomas, who is a clinical associate professor of neonatology in the University of Iowa, where she is very busy as the director of the point of care ultrasound program there, the director of the chronic lung disease team, the ECMO medical director, and if that is not enough, she is soon to be the associate medical director of the University of Iowa NICU. Her research interests are in tiny babies and the prevention and management of BPD. And lastly, I would like to invite Dr. Vesoulis, who is my co-moderator. He is an assistant professor in the Department of Pediatrics, Division of Newborn Medicine at WashU, and is the co-director of the Neuro NICU program at St. Louis Children's Hospital. His research interests include computational modeling of high-resolution multimodal physiology to illuminate mechanisms of brain injury in term and preterm infants. So as you can see, we have a wonderful group of people who are interested in neonatal hemodynamics, tiny babies, and neurocritical care. And with that, I would like to start our panelist discussion. Can everybody see? You guys can unmute. So Dr. Poorva, it is so nice to hear the different things that you're doing. One of the things that I am currently learning as a neonatal hemodynamics fellow and a trainee is the challenges of adopting a program with more targeted imaging or targeted monitoring in the NICU. So can you speak to a little bit more about how you started, if you could give some advice to someone like me who's in a NICU that doesn't do any cerebral monitoring in these tiny babies? What's kind of the first place to start? How do I convince my group that this is the thing that we really should be doing?
Thanks, Lauren. That's a great question. So I'm just going to repeat to make sure I understand the question. So how to integrate the use of cerebral oxygenation as well as targeted neonatal echocardiography. Right, that's a great question. So I think the first, and I may sound like I'm repeating what I've said in my talk, but I think the first step is the identification of the highest risk infants. So what we do in our unit is we already had an established T&E service. What we did was we identified the babies who were at highest risk of having brain injury. So we used babies who have any kind of hemodynamic instability. So babies who have either hypotension, pulmonary hypertension, or those who have sepsis, who may go into kind of a septic shock state. When we look at cerebral oxygenation values, the normative ranges that are described in the literature are varied, and they differ with the monitor that you use. So in our unit, we use the two types of monitors, and we use the cutoff of 65% to 85% as kind of the normal range. And so when we have babies who have hypotension, or who we think are at risk of developing hypotension, we start using cerebral oxygenation monitoring for them. I think, again, the use of integration of both the modalities is very important, and it's ideal, but it's not always possible depending on the availability of personnel to perform imaging as well as to interpret the data. And so one of the things which was really important was in the transitional hypotension group, where we found that babies who have intact cerebral autoregulation, likely we don't measure cerebral autoregulation, but if we only measure their cerebral oxygenation, those who had normal cerebral oxygenation, we can perhaps wait before we embark on any treatment. And that was definitely, one of the major benefits that we saw from the use of during transition, right, from cerebral oximetry. Of course, there are many other pathologies out of the transitional period where we can use a similar approach where we can guide the cerebral oxygenation values together with the physiological data as well as with what we see on the echo. For example, if we do have an infant who has a low function and a low cardiac output, as well as has low cerebral nears, then we know that we can start the treatment, such as like inotropes, and then we can see the effect on not just the blood pressure, but also the cerebral oxygenation values. And that can also help in titrating the treatment or the dosing of the treatment. So that's just giving you a few examples.
Yeah, no, that's wonderful. Thank you. Did you, and maybe some others can speak to this too. I was trained in a unit that used cerebral oxygen monitoring, and then now don't have that in my practice anymore, but have gained targeted neonatal echo. And so at one point, hopefully I'll get both of them together. Brady, can you speak to a little bit, because at least I recall, I don't know if you guys are routinely doing cerebral oxygen monitoring, but are routinely doing targeted neonatal echo. What are some things that you think are advantageous to bringing that into the unit, or some of the challenges that you may be having with bringing that into the unit?
Those are some great questions. So we do have our routine echo screening, obviously, and then we do use cerebral nears as part of Danielle's study, but it's not something that we are doing routinely in our tiny babies at this time, though we as clinicians can use it in clinical scenarios where we think that it might be appropriate. For us, in terms of implementing those practices, it was mainly looking at what is the safety to the infant, especially to our really tiny, really premature babies, making sure that they're not being stressed out by having, their targeted echoes, which we have well shown that they're not when they're done by someone who is appropriately trained in targeted neonatal echo, and making sure that with a lot of the sensors that we have to gather more information, when you have very delicate skin in a small baby early on in life, it can be, a worry for people about skin breakdown or issues there, but we haven't seen any of those issues and find that the infants tolerate them well. And then you obviously have to be educated within the unit on, how to respond to the information that you get, and to look at it within the clinical context and within the whole infant themselves. You can't take, one organ system independently and make an assessment of what exactly you need to treat or do for that infant. You have to look at the interrelated pathologies of the various organ systems, in addition to all the information that you're getting to put it into the whole clinical picture.
That's a great point. Something that I think the Safe Boost study, as well as some of the recent papers on the accuracy or inaccuracy of pulse oximetry, really is opening up this question about how we use any of these technologies, whether it's NIRS or pulse oximetry or TN echo. All of them are tools, but the way that we apply them in clinical medicine depends on the timing of when we do the test, the thresholds we use for intervention, and whether those things should be standardized, and then what actions should we take afterwards. And the results of the Safe Boost study, I think, show that those particular thresholds and those particular actions didn't necessarily make a difference, but it wasn't really a test of that technology per se. So I'm curious what everybody else's thoughts are on that.
We like to say, especially with things like ventilators, you can't test a tool because a tool can be used incorrectly. So, we're a first intention high frequency jet center, but the method by which we utilize the vent is different from even what the company tells you to do and how many centers use it. So I completely agree with that statement. You can't evaluate a tool if you don't know how it's being used and how it's being interpreted. And that's one of the big dangers about looking at large population-based studies for things like that.
And then Poorva, I'm summarizing a couple of the different questions from the Q&A in the chat here. What role do you think treating the duct, particularly using all these different markers, whether we're using indomethacin or perhaps acetaminophen or paracetamol, in a IVH prevention modality, but doing it rather compared to the TIP trial where we're doing it for every single baby regardless, as you mentioned earlier, but doing it in a more targeted fashion?
I think this question may be best answered by Souvik, who's the expert in PDA treatment. So I'm gonna ask if Souvik could kindly answer this question.
Sure. Yeah. So again, I mean, that's one of the big questions, is whether we could selectively target this physiology and demonstrate benefit if we can try and change this physiology. So as of now, obviously, apart from the TIP trial and some of the other indomethacin prophylaxis trials, we haven't seen a benefit of routine prophylaxis with NSAIDs making a clinical difference in small babies. But we have not really gone into trials where we have specifically targeted, like we've identified a phenotype using these modalities and targeted that phenotype. And that kind of brings us back to Zach's point on how we interpret the SAFE-BOOST-C results, because our interest in precision medicine came in because we had trials where we had all these different phenotypes put together. We test intervention, we don't find a difference, and therefore we use NIRS and other technologies where we are trying to tease out these phenotypes. That's great, and we feel more confident when we are able to tease out these phenotypes, and that confidence is then translated into our ability to change the physiology. That's where we need to be a bit more humble, because we still don't know what those interventions that we think change the physiology actually changes it without causing harm. And I think that's where we need to put in a bit more work in terms of trials. Say early treatment of the PDA, selective treatment, we have identified this phenotype, and let's give indomethacin or Tylenol or whatever to this phenotype and see if that makes a difference. We have not done that trial yet. I'm still seeing trials on prophylaxis, say a big trial in Europe on prophylactic acetaminophen that's going on. Really looking forward to its results. There are no more indomethacin prophylaxis trials. There are no more ibuprofen prophylaxis trials. But I haven't seen a trial where you have demonstrated with early echo that yes, your shunt is now all left to right. You have early markers of low cerebral oxygenation. Let's treat the duct at that point and see what the outcome is versus not treating it. Because if you look at the SAFE-BOOST-C protocol, people keep on saying that, okay, this was an evidence-based protocol that was employed and they found no difference, and therefore we should throw NIRS out of the window. But if you look at the interventions that were selected, they're not based on strong evidence. So it was a test of a combination of largely unproven interventions that were employed based on cerebral oximetry. So we cannot really blame cerebral oximetry for the final outcome, because those interventions, we haven't really shown that they benefit.
Sorry, go ahead.
Sorry, I was going to say also it's relying on, the people who are caring for the infants to actually interpret those data and then take the measures depending on what they think is the likely cause of low cerebral oxygenation, where we don't really know if a baby did have truly low cerebral oxygenation. Was it low because of factor A, factor B, or factor C, and whether it's kind of throwing at a treatment without actually knowing the underlying cause, and treating the symptom or the sign, which is the cerebral oxygenation, without actually knowing what was actually driving that low number, and whether that targeting that number is actually going to lead to improved outcomes.
Yeah,
I think that's
so. I mean, like, we've gotten better at identifying the phenotype using this. The next step is now finding out an effective and safe therapy to change that physiology, and that's, I think, we need to put in a bit more work, because if you come up with just physiology-based interventions and use that in randomized trials, we might get another trial which shows no difference, and then we are wondering, okay, is it the technology that was problematic, or are the interventions that are not effective?
So kind of building on this idea, and Khorshid, I wonder your thoughts on this. Poorva, you mentioned during your presentation this idea of integrating multiple sources of information together. And one of the questions in the chat is about using AI or machine learning. All the measures we're talking about, whether it's a LV output on TN echo or a cerebral oximetry, it's a direct measurement of one particular thing, but none of it's really being put together in an integrated fashion. Cerebral autoregulation is a little piece of that, but it's just a tiny piece of it. But Khorshid, I'm wondering where you think this is going in the future in terms of big data, putting together patterns of physiology, perhaps, that will help us target this management more precisely.
Yeah, thanks, Zach, and thanks, Poorva, for bringing this important topic that we all struggle with, really, between the two schools. One is clinical approach, where they all have this disbelief with the technology and the tools that we have, and the other extreme, that the newer generation that wants to really heavily depend on the tools more than the clinical sense. I think one concept I want to bring before answering your question, Zach, if that's okay, is what we are facing is more than hypoxia as ischemia, really. We need to change the way of thinking. The opposite of hypoxia is hyperoxia. If you go back to some of the early slides that you presented, there was hypoxia and then reperfusion, where the opposite of reperfusion is really ischemia. And that makes physiologic sense, because fetuses, they can tolerate hypoxia because of the abundance of fetal hemoglobin, that the affinity to oxygen is high. What we are dealing with after the first 6 hours of life is most likely reperfusion injury. And that's true whether you look at HIE, if you look at the stroke, if you look at the IVH. And that's one of the reasons why some of the intervention like EPO doesn't work, because we give it later on during the reperfusion phase. If we want for it to work, it really needs to be early on. And lots of our interventions that could be protective early on can be potentially harmful later on. So walking this tightrope in the first 72 hours is really tricky, and it needs everybody's head, a combination of clinical and technology, to make that precision medicine decision as you are proposing. I agree with Souvik, we are not there yet, but I think the fact that we are discussing it here, we are in the right track. To answer your question, Zach, I think there are lots of proposals, but I yet to see one that's clinically applicable. When I still struggle with this, I haven't found the right clinically applicable technology or platform where I can feed in all the variables from different monitors, time lock them, and then have an AI that works with that platform, that giving me a meaningful predictive model to predict early on what I'm trying to prevent. And then all the studies that we are trying to design become possible. Because right now, without that platform, without that technology, all our trials is not really possible the way we wanted it, at least. And the problem with NIRS, like what you guys all mentioned, is one thing to understand the physiology and the mechanism of NIRS. It's another thing to what to do with it. And the question I always face at the unit, we use that as a standard of care in HIE babies, the nurses will come. So what should I do with these numbers? The numbers 60 or 50 or 80. I don't have good evidence to guide their management, because our management itself in a wrong stage of disease can be harmful. And there was a very interesting study out of the Canadian Neonatal Network in 2000. They showed the variability in the incidence of IVH among the centers in Canada. They put all different variables in the regression analysis, and the variability stayed. Only when they put two variables, the variability become insignificant, and that was the use of inotropes and the use of sodium bicarbonate. And those two things speaks to our management of hemodynamics and our management of metabolic acidosis, which is one factor that I found we often don't pay enough attention to. So it's a long way to say, I don't know, Zach.
No, Khorshid, thank you for that information about this. And I think we're all kind of getting to the same point that it really is up to the physiology and being able to phenotype. And this is something that's been so transformative to me as someone who first learned point of care ultrasound, and now I'm learning neonatal hemodynamics and targeted neonatal echo. There's just so many things that I didn't realize. And you can have two babies that clinically look the exact same, and you think you know what you're doing, and you start the same drugs on them, and one gets better and one doesn't. And having that targeted neonatal echo or having the NIRS to kind of help you figure it out is very illuminating. On to some of the treatment questions that our audience has. And this is something that has come up in my practice too, of this feeling that, are we treating the PDA too early? We now know that you can see the physiology change and transition in that first 24 to 36 hours, and then the duct is now left to right. Is that the right time to treat? Would you go ahead and go for that even if there's not any change on the NIRS? Would you do it just based on the echo without other clinical markers? And then if you are going to treat that early, is it time that for us to just really be looking at Tylenol, since a lot of our babies are on hydrocort, or do we need to still go back to indomethacin? And can you guys comment a little bit on that? I can specifically ask Souvik, since he's knows a lot about the PDA and treatment.
Wish I knew all about the PDA. So to answer your question, if your center is not in a randomized trial, I mean, then I would my preference would be to treat it early if you are treating it medically, because the problem with all the medications is that none of them are great in closing the PDA late, and that's the problem. Like, you take indomethacin, ibuprofen, Tylenol. There's more and more data coming out on how even with higher doses, still it is not like you're not getting adequate effectiveness later on. So if you have echo evidence of a large shunt volume early on in a micropreemie, it is going to cause more problems in terms of most likely going to cause problems in terms of increasing IVH, possibly pulmonary hemorrhage, and its consequences that leads to then BPD and other problems. So targeting that early on with whatever medication you want to choose. Obviously, there is center preference, availability. Indomethacin is not available in some parts of the world, like in many centers in the UK. It is probably better, and I say probably because we have not proven that through randomized trials yet, to treat the duct early. But again, a precise definition using echocardiography, and I would say that along with that, clinical markers as well might help you tease out that right phenotype. And in addition to that, in terms of choice of treatment, the one more thing I would want to mention is that, yes, Tylenol appears attractive because it is safer than the others, but do we know what the right dose is on those small babies? I don't think we are there yet, because we're still using the empiric dosage that was used in the first trials. And since then, we've had a few pharmacokinetic studies that show that in the smaller babies, those doses are not effective. And even in some of the recent studies in very small babies, we find that these empiric doses leave 50% of the ducts still hemodynamically significant by day 7. So there is still work that needs to be done in terms of the dosage.
Perfect. Thank you. And Poorva, I see that you maybe have a comment on that as well.
Yeah, I was just going to add on the IVH prevention component of that as well, other than just the efficacy of the ductal closure itself. But if truly, if the mechanism that we think how PDA is involved in the causation of IVH, the earlier you treat it, that's the only time that you're actually going to find the efficacy of the treatment in its prevention, because it can have a role in both the hypoxia side of the event as well as the hyper or the reperfusion side of the events. So to be able to treat early means that you're targeting it before the reperfusion occurs, even if the hypoxia may have already occurred. So I think that's my piece just to add about the IVH.
No, thank you. That's an excellent point. Oh, sorry, Brady.
Oh, Lauren, I was just going to say, I agree with the early treatment, but I think Patrick wants to make a comment here also, and I'll defer to his comments on the topic, but I'm sure I agree with them.
Lauren, one, congrats to you and Zach for putting together a fantastic session. Just a couple of things I think are really important for the audience to reflect on, and also for the panelists to reflect on, is that we constantly strive for the magic bullet, as if at a single time point doing something is going to prevent this awful problem. And what you've heard from Khorshid, from Poorva, from many of the panelists, is that there are different elements that contribute to the problem. If you're trying to prevent IVH, there's the prevention of hypoxemia, prevention of hypoperfusion. You heard Poorva just speak about reperfusion. So it's a very, very dynamic process that we're dealing with. Now, one of the things I wanted to get the panelists to think about, because in most NICUs, people look at blood pressure. That's their determinant of whether or not there is a problem. However, where do we measure the blood pressure? We measure the blood pressure from the UAC, okay? And the perfusion pressure that you're looking at from the UAC may not necessarily be reflective of the brain perfusing pressure in the presence of a large left to right ductal shunt, in which you may assume it's low when it may not be. And you may actually have very good cardiac output and actually have a brain that's hyperperfused rather than hypoperfused, as opposed to babies with pulmonary hypertension, where you may actually not notice that the preductal perfusion pressure and the preductal cardiac output to the brain is low because your postductal blood pressure is normal. So there's the challenge I put to people. Have we actually done any study from a physiologic perspective that is actually utilizing blood pressure, NIRS, cardiac output in a much more meaningful way that interrelates, the risk that could actually help you come up with? And again, recognizing that you're going to have dynamic measures that happen over time. I apologize. I'm in a bar in an airport on the way to Ireland, so if there's lots of people going by, forgive me, but this is not a simple thing. And all I can say about the Iowa approach is based on not just a single screening echo, but also much more dynamic monitoring, much more frequent reappraisal. And I think those are key elements. If people think they're going to get one answer that will solve this problem, forget about it.
Yeah. And just to add, Patrick, not to always bring up, like my favorite organ system, but people keep talking about hemodynamic management and where is the magic bullet in that for IVH prevention. But you have to think about the fact that you need to look closely at your acid-base status. You need to follow your labs. People look at us saying we get Q3-hour labs on our, 22, 23, 24 weekers early on, and they think that that's crazy, but it's necessary because you have to follow those numbers and you have to make adjustments for them gently with time. And you have to keep all of your numbers really as steady as possible to keep your cerebral perfusion as steady as possible. You also have to look at your ventilator management. You can't have these babies, super hyper expanded, because you're going to get into troubles and you can have IVH from that as well. So you can't just look for a hemodynamic magic bullet to prevent IVH. You have to look at the baby as a whole, because there are so many factors that go into it. So if you're looking at a study and you're just saying, oh, the IVH rates didn't change when we treated, X with Tylenol, well, you might not see that based on other variability in management. But I will say, when we looked at it here in Reagan's recent paper, we did see a big decrease, and that was with our pretty consistent management in other factors: fluid, electrolyte, respiratory, et cetera.
Brady, when you said you were going to talk about your favorite system, I thought you were going to go straight to the lung and open up one of my favorite things, which is lung ultrasound. And so when we talk about building these studies and looking at physiology, Poorva did a great job of explaining just how cardiopulmonary hemodynamics can impact perfusion, not just to the brain, but to the other parts in the body. And so I think when we talk about this, I want us to start to embrace what's happening in the adult world, where they are doing tandem studies with echocardiography and lung ultrasound. And so what I don't want us to do is say, oh, we've got NIRS, there's these great studies with NIRS, we've got TN echo, we have acid-base status, and continue to move forward and forget that there's this whole other piece to the puzzle. And using lung ultrasound could be something that's very simple. I mean, there was a case series that was presented not too long ago where they looked at pre and post PDA cath closure and could actually show the babies that went on to have issues versus not. And granted, this was a very small study, but if you look at the adult literature, this is something now that their echo techs are doing. And I really think we need to remember the lungs when we talk about the heart. And remember the heart when we talk about the lungs. I think in neonatology, we sometimes get really focused on one or the other, or really, really focused on the brain, and then kind of forget that all of these other things impact it.
I think I want to piggyback on what Patrick and Brady mentioned. The challenge for us is, how can we make the complicated part of this process in the background and the user interface be as simple as possible, similar to the coding industry. When you look at any simple web browser or web page, you open the coding behind it, it's frightening, the amount of typing and coding. But for you and I, when we look at it, it's just a search engine. We type what we want. And that's one of the reasons why system like PAPIL classification or SARNA staging system or APGAR, despite us ranting about it and saying it's not predictive, everybody's still using it because it's simple. It can be applied at the bedside. The challenge for our research, for our studies, how can we bring all this physiologic information and simplify it to the bedside person? So otherwise we will stay in this elite society that we talk, but it doesn't get translated to the bedside. And that's a lifelong challenge, I think. And to Brady's point, the metabolic acidosis, that's something I wasn't paying attention enough to it. We did look at the CO2 and IVH with one of our fellows, and to our surprise, there was the metabolic acidosis was associated more with severe IVH. And then when I went back to physiology, it made total sense because the CO2 has to be converted to hydrogen ion for it to cross the blood-brain barrier. And the worst combination was the respiratory and metabolic acidosis. So that is very important.
Yeah, that's one of the reasons I really like this framing of a physiologic phenotype. I think it combines elements of all these different areas. To Patrick's point, when we're using blood pressure, I mean, we're treating babies sort of in a binary classification. You're either hypotensive or normotensive, and those are the only two options that you have. And it misses an enormous amount of granularity that could guide our treatment and whatnot. So if putting each one of these things together, whether it's TN echo, NIRS, blood pressure, lung ultrasound, lab values, all of them together, I mean, there might be and I'm just speculating, there might be 10 different phenotypes of micropreemie or VLBW infant, each of which needs a different treatment course. And I think the challenge for all of us is trying to figure out what the definition of those types are. If we can't even define which group those babies are in, we don't really have any hope of finding the right treatment for them, or at least I don't think so.
Yeah, Zach, and to add to that, not only do I feel like we have all the different subphenotypes, but then you're going to have differences in how infants respond to all of the interventions that we give for them. And so I think that's where it comes in doing, precision management, but with close follow-up of labs, of echoes, as you're adding interventions to see precisely how the infant is responding to them as well.
Just to add to that, like, for the larger neonatal community who's looking for, even on this webinar, people are looking for answers that, okay, what do I do in my unit? At the end of this session, what are the guidelines that I should take back and employ in my own unit? I think the least that we can do to start off with is centers who are trying to combine these different technologies and coming up with physiology-based management. They should start reporting their findings, like, be it simple observational data, but what are you doing? What are your outcomes? And if you have large cohorts, then you can tease out those phenotypes, and then the larger community can then kind of put everything together and say that, okay, these groups have been doing this for the last 5 years. These are the phenotypes. This is the approach they had. These are their outcomes. I think that's one starting point until we get to Khorshid's dream of putting everything together and everything working at the background in an AI-mediated algorithm that tells us what to do. But I think we can start that right now because a lot of centers are doing it, but I don't see enough reports coming out that we can follow.
So we've talked a lot about the challenges or kind of the opportunities to make this better. In terms of what we're currently doing with trials, is this something that we need to, dare I say, stop doing some of these interventional trials until we can actually get a better understanding of the physiology? Or do we accept that we aren't going to have the same numbers as the adults, and we are going to have to do some smaller trials in order to kind of figure out what's going on with these babies, rather than trying to continue to do these large trials where we don't necessarily know the question? And then, as one of our audience members brought up, are we looking at the wrong outcomes in some of these NEARS trials? And Poorva, I know you're involved in a trial right now. Kind of what are your thoughts in going into this and hearing the different questions and concerns that are coming up about really selecting the right patient population and selecting the right outcome?
Yeah, absolutely. I personally think that there's a lot more that we need to learn about just the mechanism of disease before we proceed on to any treatment trial, because I think it was a little premature, in my opinion, to target something that we don't really know what is the mechanism of that particular sign or variable. So to me, I think understanding whether it's from combined multimodal data or from big data from artificial intelligence, whichever way we are using, but really the mechanistic insights are really, really important before we think of even any kind of treatment, whether it's a medication, whether it's the treatment guideline similar to what SafeBoost used, whether it's the PDA treatment. I think we really, really need to kind of have that granularity in to be able to finish what kind of treatment is needed, depending on what is the pathology. Sorry, Lauren, you're muted.
I like Souvik's comment, because the reality is, while we want to design better trials, we want to ask better questions, we want to get this data, we also all recognize that we have babies in our unit that are being born every day, and we are pushing viability, and we have to take care of them. And so what is the better way to do that. And so maybe while we are designing these trials, we do kind of join these collaboratives like we've been doing and having these webinars so we can actually share some of our experience. And it's not as good as a large randomized control trial, but at least it's something for people to say, okay, what do I do with this 22-weeker? You know, Iowa, you've got these great outcomes. You know, Khorshid, you have an amazing neurocritical care unit. Souvik, you're doing great PDA research. Poorva, you're doing great with NERS. Like, what can we do? And then bring in Zach for epidemiology, just to tie it all together, to actually help people that are taking care of thousands of babies that are just never going to be in these trials. Which, Brady, you may be able to answer a little bit about this. I know that you were in Iowa kind of pre and post implementation of a hemodynamics program. And, you know, I can only imagine how that must have gone in the beginning, during it, and then after. Can you speak a little bit to kind of what you saw in your experience? Because, you know, the trials really aren't quite there yet, but clearly you have to take care of the babies that come before you.
Yeah, no, Lauren, I think that that's a great question. And I completely agree. I think even as we're, you know, pushing the boundaries with things, right, there are no, you know, or at least when we first started, there were no trials on anything in 22-weekers as we were treating them. I think that you have to just look at it with science and with reason and examine your physiology as best as you can and find treatments that make sense and then follow very closely for the response that you see. We certainly can't wait for there to be a randomized control trial on everything that is done perfectly. It's simply not going to happen. And while some of our interventions may cause, you know, a side effect, not treating these things causes, you know, harm to the patient sometimes also. I think it's, you know, trying to kind of slowly introduce things that make sense to us as, you know, neonatologists, as clinicians, with the introduction of the hemodynamics program. I mean, you know, we're always very protective of our patients, right, as neonatologists. And so we did have, you know, these crazy Canadians coming into our unit and wanting to change some things, but really wanting to build upon what we already did. And they led with
from your Canadian panelists and speakers here.
They led with physiology, they led with science, you know, they led with what evidence that they had. And then we tried to bring those implements in slowly so that we could see that they're safe and that they're effective. And you don't want to change too much drastically with your management, you know, all at once, or you're not going to know which of those interventions made a difference. So like I was saying with, you know, Reagan's paper on, you know, IVH with our PDA screenings and the treatment that we were doing, we're a unit that is very consistent in our management. I'm working on a paper right now about ultra low birth weight infants and our respiratory management of them. And it's like, we're trying to talk about what the CO2 range is in these babies in the first week of life. It's just within our parameters. Like, that's how tightly run we are. I'm like, this is funny. We all follow our own protocols so well. But so not a lot else has changed, you know, between those two interventions, which I think you kind of have to just look critically at studies and the evidence that you get and see, you know, are there other factors I think that could have, you know, interfered with the outcome, and think critically about it. But we have to move ahead of randomized controlled trials.
And if I want to rephrase what you said, Brady, I call it the art of science. When you pick from different research and published paper, you tailor it to the patient at the bedside. And the second point that you mentioned, when you have this approach, you are putting the unit at risk of variability. So the second part is kind of the safety valve or guard or gate to the first point you made, is really to, as a group, to put our heads together and reach consensus, because whatever we come up with, whether it's a bundle or protocol, it will never be perfect. But we need to agree that we will live with it for a certain time period, 6 months, 1 year, and we have a way to study it. Because with variability, there is no way for you and I to know that this intervention have made difference or made the matter worse. So consistency and decreased variability is key in implementing variable research out there and improve it in a PDSA type cycles. And one of the examples from our own experience was extubation and reintubation, because we had lots of variabilities who we intubate at what time, when we extubate them, and when we extubated them, when we reintubate them. So to eliminate variability at the first stage while we were working on our extubation and reintubation protocol, we said every single baby less than 27 weeks, we will keep them intubated for 72 hours. That wasn't ideal, we know, but the variability was even worse. So, and then once we came up with our protocol and we agreed on, only then we start to drop the gestational age by 1 week systematically. So variability and consistency is the key, I agree.
On the flip side, though, I would mention that we should not ignore clinical trials, because at the end of the day, that is the best way to get unbiased evidence. So once we have defined our phenotype, because that has been the biggest problem in our trials, is that the inclusion criteria has been too broad. So once we have defined the phenotype using all this technology, and you have more than one intervention where there could be patient important benefits as well as patient important harms, I think that's where you should spend the time and money to do trials, because otherwise a lot of the times, and there are tons of examples of this in adult medicine, where something that made perfect physiologic sense after a trial has been disregarded because it was proven to be harmful.
Yes.
So just to keep that in mind, that there is a place for both, but we should pick. And again, I agree that not everything needs a trial. Whenever we are fairly certain there is probably no harm or little harm, then that's where we shouldn't be spending our money. But when there is equal benefit or harm, I think that's where we should push for trials.
No, and I thank all of you for sharing your very different experiences and bringing your knowledge to this group. It sounds like there's a lot of agreement that we need physiology, phenotype-based clinical care, and we both have to be able to take care of the babies that are in front of us and use the resources like everyone here on this call to help, but not forget some of the lessons learned the hard way of doing things that seemed to work in the short term, but then long term had some pretty disastrous impacts. So I want to thank everyone, Poorva, Souvik, Khorshid, Brady, and my wonderful co-moderator, Zach, for taking the time to be with us today. Poorva, what an amazing talk and very exciting research that you're doing. And I look forward to hearing the outcomes of these trials. Thank you, everyone.
Thank you very much, everyone.
Bye.
Bye.